per kilogram per hour. And then some of these other numbers, where do they come from? 10 mils per kilogram for patients under surgery. Is that really necessary? And if we start to look at trauma patients, for example, this comes from 1918, Walter Cannon and John Fraser, who started looking at it and said the injection of a fluid that will increase blood pressure has dangers in itself. Hemorrhage, in a case of shock, may not have occurred to a marked degree because blood pressure has become too low and the flow too scant to overcome the obstacles offered by the clot. If the pressure is raised before the surgeon is ready to check any bleeding that may take place, blood that is sorely needed may be lost. And this perhaps in 1918, what they were talking about is hypotensive resuscitation, resuscitating to the lower end point of blood pressure. These are trauma patients. What fluids should we be using in trauma patients, and what are our goals? These problems, by the way, have been well recognized besides from Walter Cannon and his group. Becher in World War II described a similar problem where he said, well, if we can just achieve 80 to 85 millimeters of mercury as a systolic pressure, maybe we should just be happy with that until we've controlled blood pressure. Bicknell, 1994, a similar type of approach. He said, hold on, in massive trauma patients, pick them up, run with them, take them to hospital, and then try and resuscitate them once we've controlled hemorrhage. It relates to that golden hour of trauma. And so the evidence carries on, 1990, 2006. So it starts to change that concept because we've all been taught for a long time in a trauma patient, let's resuscitate them, let's give them 90 mils per kilogram per hour and resuscitate them till perfusion occurs. And what these guys have all said is, hold on, maybe we should use a little bit less. There's a consequence, and this comes out of the Vietnam War. They first described it as Da Nang lung, but it was pulmonary edema following the administration of fluids to soldiers in Vietnam. So fluids have consequences, and I hope tonight to address some of those consequences, stimulate some thought patterns, and then hopefully give you some advice about where we should be heading with our fluid rates. So that little dog in the bottom corner is my own case of Da Nang lung, a septic patient, and you can see some of the wounds still there on his hindquarters, who in the space of 1.5 days, I added nearly 2 kilograms to his body mass. That was excess fluid. Fortunately, we were able to turn things around, but it's not always going to be the case. If we have a look at it, and these essentially on the slide represents the 3 major types of fluids we have: blood and the blood products that are related to there, our crystalloid fluids, particularly represented by resuscitation fluids, but we also have maintenance fluids, and on the other side, our colloids. And I'm sure you're all aware recently colloids were taken off the market. And it's this gentleman who's responsible for it, Joachim Bolt, who's currently under criminal investigations, mainly because he forged studies. He was also responsible for a large portion of the registration works of Voluven and the other colloids that were registered. And of course, once his research was withdrawn, well, there was no evidence to support their use. So he took away colloids for us a while, but I'm sure as you're aware, they've already come back onto the market. Their registration has changed, the indications have changed, and they have some contraindications, a warning for us. But are they really that bad? This is the study, by the way, that finally led to the controversy over hydroxyethyl starches. They compared it to Ringer's acetate, is what they used, and they looked at probabilities of survival to death. And in this graph, you can see over the next 90 days since randomization, the Ringer's acetate graph, which is above the Hess starch, they've clearly split. They're statistically significant, that the hydroxyethyl starches were resulting in more mortality compared to Ringer's. And there may be something very important on the slide, that they used Ringer's acetate, not the other fluid that's always been talked about in the literature, which is sodium chloride, good old saline. Just remember one thing, most of the colloids to prevent hemolysis are formulated in 0.9% normal saline. And we'll come back to chloride and how chloride affects the kidneys. Just keep that in mind for the moment. But this is the other way of looking at it, looking at relative risks and the risk index and the risk for acute injury. And you'll notice there that certainly it was better to receive Ringer's acetate than a hydroxyethyl starch, also as far as your kidneys were concerned. And as I say, is that a problem because of the chloride that is present? That may be very true, because that is present in the hydroxyethyl starches. Or is it solely because of the hydroxyethyl starches? And we'll have a look at a bit more of that information in the next couple of slides. We also have this problem. We have maintenance fluids and we have resuscitation fluids. When do we use them? And I'm sure those of you who have followed electrolytes in patients, when you keep using resuscitation fluids, over the next 2 or 3 days, they all become hypernatremic. They accumulate sodium. And that's because of our resuscitation fluids. Maintenance fluids are designed to be low in sodium. But what also happens is, with our resuscitation fluids, they low in potassium. Our patients become hyperkalemic. So what do? We add potassium to our resuscitation fluids. And slowly, we actually just mix up a maintenance fluid. And maybe we should be using both of these fluids together, because resuscitation fluids continually used create problems, but so do maintenance fluids, because we cannot push maintenance fluids in fast at all. So we can't use them for resuscitation. And it's something that we need to think about as we use fluids. So I just wanted to take you back to some basic physiology at this point, to remember about our total body water. And this is based on Guyton's physiology, so it's a human. Us adults have about 42 liters of water. It's about 60% of our body mass is water. And that water is divided up into intracellular fluid, which is the dominant portion of it, 28 liters of intracellular fluid. And that means the remaining bit is extracellular fluid, about 14 liters of extracellular fluid. The extracellular fluid is then divided into interstitial fluid, about 11 liters, and blood and plasma, about 3 liters. And of course, that blood and plasma is then split into our cellular component, mostly red blood cells, and the fluid and protein portion to it. Now, when we administer fluids, most oftenly we're giving it intravenously. We're giving it into the blood compartments. But the fluids distribute throughout our body, and different fluids behave differently. So the fluids distribute in the system, they're based on the electrolytes that are in the system and the other components, for example, glucose. And with that, they will distribute throughout our body. So to look at a rather complex slide, it's just that everything's been reversed, so our plasma and our blood cells are now on the left-hand side, and our interstitial and intracellular fluids are then situated in the middle. If you look at the first line of glucose, if we take dextrose water, which is what it's based on, our liver metabolizes the glucose or removes it from circulation, and we're left with free water. And something like glucose will distribute between intracellular, extracellular fluid, and all the compartments. When we start to replace dehydration, a fluid like this will distribute quite rapidly between all those compartments to replace an intracellular fluid deficit. If we look at saline, which is just there to represent the crystalloid, so it could include Ringer's lactate and so on, they rapidly distribute between in the extracellular fluid, between our interstitial fluid and our blood. And why does it happen that way? Well, our resuscitation fluids are largely high in sodium and sodium chloride, and that is kept out of our cellular component. Our cells are low in sodium, represented by that blue bar, but our cells are high in potassium. They've got proteins, phosphates, and so on. So something like sodium chloride, because of the sodium and the chloride, and that cells actively pump it out of themselves, will distribute between the interstitial fluid in our blood. The colloids were designed then to stay in our intravascular space and fill it up. So the distribution of these fluids will change and will cause fluid shifts. A maintenance fluid has glucose in it, it's higher in potassium, it's lower in sodium, and so tends to distribute better into the intracellular compartment or faster into that intracellular compartment. It's something to think about in our fluid choices. Think about that dehydrated puppy who's got gastroenteritis. Maybe a maintenance fluid would distribute faster and replace his cellular dehydration faster than, say, a resuscitation fluid. But they're hypertensive when we see them. They've lost this fluid, they've lost intravascular volume, and we need to fill that up as well. So it becomes an important concept for us to think about the fluid we use and how will it behave. Don't forget about Frank and Starling's laws, the filtration pressure across our endothelium inside our capillaries, that the pressure inside pushes fluid out and it creates filtration. That fluid contains nutrients, some oxygen, etc. that our cells desperately need. And of course then the fluid moves back in based then on the oncotic pull. The interesting thing that we now know is that the oncotic pressure of both our interstitial space and that in our capillaries is pretty much equal. So they believe the oncotic pull pressure is no longer as important as what we believed it was. But the concept's quite important. But within this endothelial thing, we've got one important component to it, and that's the endothelial glycocalyx, a proteinaceous layer that regulates fluid movement across the endothelial barrier. When that becomes sick or dysfunctional, it allows fluid to move freely across our endothelial barrier. I put this in now because we need to think about it. Do fluids affect outcome? In some ways it's a stupid question. The answer is obvious, and it's yes. If you have a look at a volume load, we have an optimal range where we get the best benefit out of a fluid. If we've given too little and we've got hypovolemia, we have organ dysfunctions, hyperperfusion, lack of oxygen, and of course that's bad. On the other hand, if we give too much, we get edema, lung edema for example, again, organ dysfunction, and bad things happen. And there seems to be this optimal range where we need to get our fluids to make our patients better. Too much is bad, and too little is bad. How do we get to that optimal balance? It's something we need to think through. So to come back to the colloids, we said yes, they are damaging, they're detrimental to kidneys. That's true. That data is most probably more than 20 years old now. And a lot of it came from originally looking at resuscitating renal transplant donors. And when they were resuscitated with crystalloids, they had excellent graft function. However, when those patients were resuscitated with colloids, the transplanted kidneys didn't work as well. But we get iatrogenic effects, the hyponatremia, the hyperkalemia from too much resuscitation fluids. We also get the organ edema, the GIT edema from too much crystalloids. Colloids has been shown, by the way, to reduce GIT edema, and that's been shown extensively in abdominal surgery, where they've done resections of the gut. Patients who received extensively crystalloids developed gut edema and an increased dehiscence. Patients resuscitated or treated with colloids for their hypertension whilst they're undergoing the surgery developed less edema of their incision sites, there was less dehiscence, and so on. So there's perhaps an advantage to colloids that was then in surgical patients. I talked about the glycocalyx, this layer in the endothelial barrier that regulates the fluid that crosses it. In sepsis, we lose it, and it disappears. It allows both inflammatory cells to freely leave. It allows platelets to do damaging things and adhere to our endothelium. It creates a whole activation of things. And if we could keep that glycocalyx there, we could keep fluid inside our circulation very, very easily. The interesting thing is that they found that albumin has a protective effect on the glycocalyx in sepsis. And I'm sure you may be aware of it. There was a big controversy of a published study that said albumin kills septic patients. And then a whole lot of people went and said, no, this is not true. Maybe we're sitting at that point with colloids at this moment. I wanted to show you this. This is the effects of fluid resuscitation on mortality and organ function in experimental septic models. And if you look down, I've just got to get my cursor. If you look down here at the bottom, these experimental models were given endotoxins and high volumes of fluid, and peritonitis and high volumes of fluid. Look at the percentage of survival, exceptionally low. You move up to more moderate volumes of fluids, and whoa. More moderate volumes of fluid, and here right up at the top where we have small volumes of fluid giving, we have the best survival. It's almost counterintuitive, because what are we taught? Well, let's give fluid. In our resuscitation patients, in our septic patients, give them fluid, give them lots of fluid to make them better. I wanted to show you this. And this study, in actual fact, could never have been performed in a first world country. It was performed in Africa, and they looked at mortality after fluid boluses in African children with severe infection. And they had a choice. They could receive albumin resuscitation, saline resuscitation, and the bit that says no bolus means these patients were given a constant rate infusion of maintenance fluids. The top two lines, mortality, reaches just over 10% in the albumin and saline bolus groups, and about 6% in the no bolus groups. That difference, by the way, was both at 48 hours and a mortality of 4 weeks. It goes against a lot of thinking and thoughts that have been put out there in the world that says lots of fluids are good. Let's give lots of fluids. Let's resuscitate patients. We're going to save more. The whole concept of early goal-directed therapy is driven on that basis. And they've made recommendations of up to 30 mils, 60 mils, 45 mils per kilo changes every time the guidelines are updated. But in actual fact, over time, perhaps the amount of fluid we should be giving is coming down. But it's an interesting study, this, because it challenges conventional thinking. This is just, by the way, looking at a whole lot of other things. Yes, some of the patients had malaria, relative risks, whether it favored a bolus or no bolus. And you can see there, even for reducing lactate, it favored the no bolus. Base deficit, an idea of acid-base balance, was better if you didn't give a bolus of fluid. Hemoglobins were better if you didn't give a bolus of fluid. And so the benefits continue down that side. So the no bolus was better when they looked at a whole lot of different variables. Interesting and challenging to conventional thought. This is a different way, and it's looking at fluid accumulation, and I'll show you the formula for fluid accumulation later. But it's the amount of excess fluid we've given to a patient, and looking at survival and recovery of kidneys in critically ill patients with acute kidney injury. And it didn't matter whether you dialyzed them or you didn't dialyze them, looking at mortality. And what is written along the bottom of the graph is your percentage of fluid accumulation relative to baseline. So it's based on weight and then your fluids in and fluids out. And basically you take your fluids in minus your fluids out and you divide it by the weight of the patient. And that'll give you a percentage if you multiply it by 100. And you can see if you had a 10% loss or more than a relatively small loss, you had a good chance of survival, a low mortality. And but by the time that fluid excess reached 20, mortality had reached nearly 50, over 50%, nearly 60%, showing that a fluid excess was bad. It correlates to a higher mortality. So we talked about chloride, saline, giving liberal chloride versus a restrictive chloride intravenous fluid strategy. And this has been recently published. And they did this in this hospital. What they did is they had a control period where they allowed the people to continue their current practice using saline as a resuscitation fluid. And then after 6 months, they had their intervention and they reduced the use of chloride-containing fluids within the resuscitation of patients. And they had a strategy to do it. What did they do? Well, if you look in the control period, 71 developed risk for renal injury, 48 developed injury, 57 went on to failure, and 105 had both injury and failure. Once they restricted chloride fluids, the numbers come down significantly. 57 only in the risk group, 23 who developed injury, 42 who developed failure, and only 65 who had both injury and failure. And that was statistically significant. And the question that it was brought up is that we've known for a while that too much chloride is bad for your kidneys. So it's changing a thought paradigm about how we use resuscitation fluids. And saline is the one that's always very well published. It was the first one used, is a high chloride containing solution. To have a look at it slightly differently, this is looking at plasma chloride levels. Hyperchloremia after non-cardiac surgery is independently associated with increased morbidity and mortality. And looking at the probability of death, and you'll notice that the line tends, if it gets very low, to go up. But you can see as chloride moves up, and certainly above our normal range, in actual fact it increases the probability of death. So when we are designing fluid strategies in our patients, it's something to think about. Maybe the chloride also just goes with the sodium because it's very often attached onto a sodium molecule. But we have other sources of chloride as well, potassium chloride, for example, that we do add to solution. So it's something to think about in designing our fluid strategies. So we need to look at something perhaps a little more practical, because it's great having all this theory, but what do we really do with it? And how do we resuscitate patients? And this is what has been and what's been put out in guidelines recently, is we have hypertensive resuscitation aiming for a systolic really of not more than about 90 millimeters of mercury, or a mean of about 60 millimeters of mercury. And that's perhaps my first couple of slides that were summarized there. These are trauma patients, patients who are actively bleeding at the moment. Giving them lots of fluids just makes them bleed more. We head towards a dilutional coagulopathy because we push up blood pressure, they bleed more out into their abdomen or their chest. We fill them up with fluids, they bleed more out, and all we do is dilute out the clotting factors. Then they've always suggested large volume resuscitation for SIRS dogs, hypovolemic dogs. Give them crystalloids, give them a boluses from 10 to 50 mils with some colloids. You could even use oxyglobin. And that small volume resuscitation should be reserved for cats and perhaps those patients in heart failure. Give them smaller doses and see what happens. And I want to challenge really the large volume resuscitation. On some of the evidence I've given to you now, is that really appropriate? Aren't we just pushing edema? Can't we make renal function worse? We know that large volume crystalloid resuscitation, for example, in trauma patients is associated with the development of lung edema. And there's good data to support that out of the ARDSNet study. So where do we actually sit? How much should we give for surgery actually? And that's really controversial because we have this thing that says for major surgery give 10 mils per kilogram per hour. And why not use maintenance rates? And I'm going to put that out there for you. Do we really need to use 10 mils per kilogram per hour for major surgery? If it was less in minor surgery, maybe 4 mils, maybe 6 mils. Do they need that fluid? And at this point, I want you to think about your daily fluid intake. You wake up in the morning, you have a cup of tea or a cup of coffee, maybe some fruit juice, and your next drink may be around lunchtime if you've had a really busy day. Or if it's really busy, maybe it'll be that evening. But your body regulates the fluid. You don't take in fluids all the time. Do our patients need fluids all the time? Just a question. Dogs themselves don't drink continually all day, at the required maintenance rates. Now I want you to start thinking about, maybe we need to just give enough. Just enough to maintain normal perfusion. I have a question. How do we do that? And I hope to give you some answers to that. Yes, I was a little bit horrible earlier about the early goal-directed therapy study, but it significantly changed human mortality, the RIVERS study, in sepsis, introducing the concept of early goal-directed therapy. And they started off and they said, give bolus of crystalloids every 30 minutes till you raise the CVP to 8 or 12 millimeters. If that doesn't work and you've got a good CVP but you're not delivering oxygen, then we start a positive inotrope and we sort blood pressure out. This was their original goals. But perhaps they were giving too much fluid. Maybe we could save a few more. I think there's an important concept in the early goal-directed therapy, and this certainly Rivers introduced us to, the object of oxygen delivery. He measured central venous saturation to determine that. In other words, that the blood returning back to the heart after all the cells have got oxygen, that saturation was high enough that oxygen was not rate limited. Maybe that concept out of what he drove for is the most important part of it. Yes, we need a normal blood pressure, and we need a blood pressure of about 60-65 millimeters of mercury, and I'll show you why in a couple of slides' time. So blood pressure is important for us for perfusion, but also other markers that we need to look at. That out of interest was his data and the effect on mortality, the standard therapy, and the blue lines, his early goal-directed therapy. And you can see a significant reduction in mortality with this program. He needed to treat 6 to 8 patients to prevent 1 death. That is quite phenomenal. He had actually significantly improved mortality. But these days they are looking at refinements to what he originally proposed to make this and perhaps improve these results. I put this horrible table up here, not for you to read everything, but it comes out of how to manage trauma patients. And it introduces that important concept. If you look at the second column, it talks about symptoms. In mild trauma, you've got maybe a palish mucous membrane, a fastish capillary refill time, some tachycardia, and strong pulses. And if you go down the list to more severe trauma and catastrophic trauma, those muddy mucous membranes, delayed capillary refill times, you can either have tachycardia or bradycardia, pulses you can't feel, peripheral pulses that are absent, just no blood pressure. And you look at the fourth column, and it talks about endpoints. That's the important part to this. Driving those pale mucous membranes to becoming pink, the muddy mucous membranes to pink, a normal capillary refill time, getting a blood pressure of 60 millimeters of mercury. But it also takes away a concept that says, hold on, don't just push 90 mils per kilogram an hour in the first hour to resuscitate your patient. Maybe we go back to the cholera epidemic. He gave an ounce, he saw the response. He gave an ounce, he saw the response. And that's what we should start to look at. And certainly this table gives us many useful points to look at for guiding fluid therapy. So optimal dosing of fluids is the concept we need to think through. Goal-directed fluid is helping us, maximizing cardiac output, looking at the surrogates we have, blood pressure, pulse oximetry, capillary refill time, mucous membranes. Don't forget about mentation. It's very, very important. What do we give? Well, we're going to talk a little bit more about this, but certainly we need to use maintenance fluids and we need to use resuscitation fluids. We need to use colloids. We need to use all of them. It's not a fair comparison to say, oh, we resuscitate everything on hydroxyethyl starch or ringers. That's not how we clinically use it. Clinically, we use a little bit of everything to make it work. And certainly I have patients who are receiving maintenance fluid, so I'm giving them a low sodium fluid that's high in potassium with some glucose and a few of the other electrolytes that are non-resuscitation fluids. And then I add to that resuscitation fluids because that may be there to replace an ongoing loss. They may be in polyuric renal failure with a high filtration of plasma and a large sodium loss that's happening through their kidneys. So I give them some resuscitation fluids to replace that. And I am supporting them with some colloids. Maybe it's plasma. So clinically, I certainly do use all of them. So this is something to look at. This is a human study on the hemodynamics and variables of septic shock. But I'm just showing you the graph that relates to blood pressure. And if you look at the area of the graph where the mean blood pressure was below 60 millimeters of mercury, and the time that the blood pressure was below 60 millimeters of mercury was a high correlate to mortality. So the values for hypertension, especially under 65 millimeters of mercury, were well correlated to mortality. So blood pressure is important for the perfusion of organs. It doesn't tell us about cardiac output. But to look at it a different way, this is blood pressure measurement in ICU patients and ICU mortality. And looking at mean blood pressure, and you'll notice here at the point about 60 millimeters of mercury, we're at the nadir where mortality is at its lowest. And any blood pressure or mean blood pressure higher than that doesn't improve survival benefits. But when your blood pressure was at 50, 40, your mortality was high. So it's important to pursue blood pressure and maintain a normal blood pressure. Just remember, fluids are not our only strategy. And I don't have a large number of slides looking at our other strategies. But we have positive inotropes and vasoconstrictors that we can also use to manage blood pressure, not only fluids. So the target of blood pressure becomes critically important. This is another way of looking at giving fluids. And here they're monitoring SV, stroke volume, for example, or an assessment of cardiac output. And that gives small boluses, 3 to 4 mils, and here they just use the example of a colloid over 5 minutes and see what happens. Stroke volume increased by less than 10%. And they have a look at it, and looking at the Frank-Starling curve, which is right at the bottom of the graph, you're most probably on the lower end of the curve, so give some more fluid. If you start to get a nice increase in fluid, you may be reaching the top of Frank-Starling's curve, and we should most probably hold off and say, hold on, that's it, we're not going to give any more fluids. The point we want to avoid is point C on that curve, where we've given too much fluid, because those are our patients who are becoming edematous. So we talk now about fluid responsive patients. Because some patients really benefit from fluid, we give them a small bolus of fluid, their cardiac output picks up, their oxygen delivery improves. But these are slides on septic patients. And when patients develop sepsis, they in effect develop a dilative cardiomyopathy. That's what it would look like on ultrasound. Their heart chambers get bigger, their contractility decreases, and they become less effective in ejecting blood. So sick patients can develop this call it a reversible type of cardiomyopathy that certainly is reversible. And they do need some fluids, because if we look at a patient with heart disease and dilative cardiomyopathy, they need an optimal preload. Too much preload is bad, and too little preload is bad. But if patients are not fluid responsive, we have a real risk of giving them a fluid overload, and that leads to edema. So this was just put in here because those of you who do invasive blood pressure, a lot of work has been done on humans looking at pulse pressure curves and an analysis of those pulse pressure curves to determine optimal filling. It's not foolproof, but it does work, that you can see changes in pulse pressure curves as you give fluids. And they talked about this as being pulse pressure variance. And I'm just going to show you 2 examples. There's about 4 variables that you can measure of invasive blood pressure. But they talked about systolic pressure variance. And effectively what it is, it means by stroke volume we have a variation in cardiac output as we breathe in and as we breathe out. It changes our intrathoracic pressures, which changes the preload on our heart. And that causes changes in our pulse pressure variance, and that is most likely due to hypovolemia. So what would happen is you would notice these pulse pressure variances, you give patients fluids, until all the systolic peaks are all at the same height on your blood pressure curve. That is there. By the way, pulse pressure variance is and does have some problems with it. It's not perfect. They've also looked at ultrasound, and that's something I always believe all critical care people should have an ultrasound machine attached to their hand. It's incredibly useful. You can go and look at the heart, go and look for that dilated cardiomyopathy. But you can also look at the large vessels returning blood back to our heart. Okay? And there is a difference because of how the intrathoracic pressures change between mechanically ventilated patients and spontaneously breathing patients. But if we go and look at something like the vena cava, how it changes during the ventilatory cycle, you can measure the diameter of the vena cava and look at how it changes between inspiration and expiration. And if you change that to an M-mode view on your ultrasound machine, you can see the vena cava as it goes past in front of you. You'll notice in hypovolemic patients it collapses completely. Maybe these patients need fluid, and you fill them up until the vena cava looks like that slide. And this, by the way, they would normally measure this, the vena cava, just in front of the liver to do it. But you can see those changes as they happen. So we can use ultrasound to look at volume responsive, and if we're really good with our ultrasound, we can measure the aortic velocity or the cardiac output that's there, and give a bolus of fluid and see if we actually improve cardiac output. So when you get volume overload, by the way, which this may also help us, there's almost no change in the vena cava. It looks really large and big and doesn't change with time. Well, what about using lactate? And lactate can be really useful for us. We can take a GDV that's come into our clinic, it has a lactate of 9, give it fluids, resuscitate, and if that lactate comes down, we know we've got a better chance of saving that patient, and that's true. Lactate itself is not perfect, because in septic disease, because of changes in adrenergic receptors that happen, lactate in actual fact may not become a reliable indicator at all. But this was a study done of lactate in relation to cardiac output. And all I wanted to show you is that really the lactate didn't correlate with any form of oxygen delivery, which is what we know is true in septic patients. So it's a useful marker for us. And yes, I use it, although it's not perfect. If I can get my patients to clear lactate over time, that's useful. And I hope and I believe that it's clearing lactate because I've improved oxygen delivery. But it's not a perfect mechanism that is there. The other fascinating thing is that oxygen delivery in critically ill patients remains unchanged from healthy patients. An interesting concept. About 4 mils per kilogram per minute is our critical point of oxygen delivery, and sepsis does not alter critical oxygen delivery, which is interesting because it challenges the lactate theory of how it correlates. It was done quite a while this way, but it also raises that probably that increasing oxygen delivery may be inappropriate. And the time this research was done was at the time that Schumacher proposed his theory that supra or above normal oxygen delivery was the way to go. And yes, this research certainly challenged that. These days the philosophy is let's just try and get normal oxygen delivery, not more or anything more than that. So how do we practically do fluids? And this sheet is most probably one of the most practical ways of doing it. It's that classical fluid in, fluid out sheet. What do we put into the patient? It's our intravenous fluids, whether it's maintenance or resuscitation fluids, our colloids or blood products that we're giving as well, and everything that leaves that patient. The urine that leaves, diarrhea, and what fluid leaves out of the stomach. And I know that there's some controversy behind it. Should we use nasoesophageal or nasogastric tubes? I'm partially a nasogastric fan because I like to place the tube all the way into the stomach. And then what I can do is see how much reflux comes out of the stomach. so I can drain it every 2 hours. To me, one of the great perks is that vomiting dramatically decreases because the stomach never gets full. But on the other side, when the patients start to get better, your stomach starts to get motility back and you stop sucking fluid out of the stomach. So it's a really useful way of also assessing gastric function and flow. And you work out that. So how much fluid did we put in? How much fluid did we get out? And what's the middle road? So it's very, very useful. And down the left-hand side, I usually plot urine production because urine to look for renal injury becomes important. And one of those markers is when you don't produce 0.5 ml per kilogram per hour. Certainly for more than 6 hours is of a concern. If it's maintained for 12 hours, you do have some form of renal injury. So it helps us to assess renal function, which is a useful part of it. Don't forget about edema checks, another important part of what we're doing to balance our fluids out. Also account for all oral intakes, nasogastric tubes, esophagotomy tubes. And I'll put you here, isn't the oral route not preferable? For certain patients, and if they can tolerate olive fluids, do they really need a drip line? I just like to always put it out there just to make people question, do we need an intravenous catheter? What are we using it for? And why is it there? This is the formula for fluid accumulation. Fluid in minus fluid out divided by your baseline body weight multiplied by 100. And that's what that graph that I showed you earlier based on renal function is based on, this formula. But we know that a 10% increase in fluid excess is directly correlated to mortality. And in humans, they start dialysis, not necessarily to treat renal dysfunction, but to control the fluid balance. So the aim here is to get a patient to fill up their vasculature so that they've got an optimal preload and try not to give them too much more than that. That's the first principle that we get to. Well, what about acute blood loss? I love this slide. It's doing nasal surgery in horses. Haven't done it for a long time since they started injecting ethmoids with formalin and so on. But they could lose liters and liters of blood in trauma patients. And if we start to look at now the experiences that have come out of Iraq and the Afghanistan conflict and so on, the armed forces use a walking blood bank. And they resuscitate patients with fresh blood. In our settings, yes, we can use fresh blood, or we can use packed cells and fresh frozen plasma to do it. And if that's used, it is way more successful than using ringers or other resuscitation fluids. And in trauma patients, we know that the amount of crystalloids given, the higher the volume, the more it's correlated to mortality. In the Iraq conflict, they had patients that received over 100 units of blood and survived. So in trauma patients and massive blood loss, the best benefits seem to come from giving blood, fresh blood, and if not fresh blood, certainly fresh frozen plasma and packed cells. If we're going to use fresh frozen plasma, packed cells, or whole blood, remember it contains usually calcium EDTA, a calcium chelating agent of sort, and we need to put back calcium into the body, because if you become hypercalcemic, that's also a negative inotrope. So calcium replacement does become important, and that needs to be monitored the whole time. But the best success rates are managed by resuscitating the patients with blood. Where do they start? Well, they started off with those targets we talked about right in the beginning. Let's try and just get a systolic of maybe 90, a mean blood pressure of about 60. Control the hemorrhage, and then resuscitate them back, hopefully more towards a normal blood pressure, once we've got the hemorrhage under control. So that certainly is a better approach. And for those of you that are interested in it, the use of tranexamic acid in trauma patients is also associated with a significant reduction in mortality. And it's a treatment that has relatively few side effects, is very cheap, and because of that, most of the resuscitation people are encouraging the use of tranexamic acid in trauma patients. These drugs are undoubtedly going to play a more important role in treating our patients and normalizing their blood pressures and their perfusions. Or we could look at them in another way. They're fluid-sparing drugs. And the drug of choice, although it's not as easy to get hold of, is certainly noradrenaline. It's a highly effective vasoconstrictor. And we need to remember that most of our blood sits in our venous system, not in our arterial system and not in our capillaries. Our venous system is a venous capacitor system. So by having a vasoconstrictive effect of noradrenaline on our venous system, we can push a lot of blood forward into our circulation. It's important to remember in septic patients, a lot of them develop vasodilatation. By increasing vasoconstriction, we actually improve our perfusion just purely by giving them vasoconstrictor, we can use a lot less fluid to do it. Dobutamine is an important drug to support cardiac contractilities. I showed you some evidence. Noradrenaline certainly would also have some effects on cardiac contractility as well as adrenaline. There is a move, by the way, in patients who are in vasoconstrictive type shock, and even in other types of patients because of the microperfusion abnormalities, to certainly consider using drugs like nitroprusside and nitroglycerine. So they're drugs that are coming out as a thought process to say, maybe we should think about using it. But certainly our positive inotropes and our vasoconstrictors are becoming more important to limit the amount of fluid that we give. The aim of fluids, of how much should we give, is to normalize perfusion. That's how much we should give. Just enough so that we can start to normalize perfusion. I think that concept becomes very, very important for us. Does the actual numbers matter? Most probably not. That is there. So start to look for responses. And look for responses in those patients to the volume we've given. And if we look at shock patients, they have cold extremities usually, cold ears, cold feet. Are we warming up those extremities? Are we improving the warmth of those extremities? Look at neurological status, that dull, obtun type patient. So they're suddenly becoming a more lively type of puppy. That is very, very important. I always say, listen for borborygmi. Our gut is one of our shocked organs that are present. Then the moment they lose perfusion, they become quiescent. Just remember, if they have no food, they have no reason to move either. But listen for those signs. I always say that then it's always horrible when those dogs produce those profound, smelly, bloody diarrheas. It stinks. But hey, the gut's starting to work. That's good. It's not a bad thing when that starts to happen. Yes, I do use blood lactate. No doubts about it. And I look for a decreasing in that blood lactate. The 9 that becomes 4.5, that becomes 2, that becomes normal. It tells us hopefully we are heading in the right direction. So I think it is something that's useful. Look at blood pressure. Let's try and keep that mean above 60, 65 millimeters of mercury. If we can start to achieve that, we're making progress. So in resuscitating our patients, it's not so much about a volume. It's about remembering that goal. Remember, in dehydrated patients, we still have a deficit that we need to replace. It's important to replace that deficit, that we do give them that fluid to replace the dehydration, the intracellular fluid that's been lost. And just remember, in those patients, in actual fact, something like dextrose water or a maintenance type fluid may be better at replacing that intracellular dehydration than what a resuscitation fluid will be. We can use both together. There's no harm in doing that as well. We can use combinations of fluids together. I'm nearly at the end of my talk, but hypovolemia is extremely common. In studies, 50% of human patients in ICUs can have hypovolemia. So it's something that we need to actively look for. And whether we do it by fluid responsiveness and looking at a fluid responsive test, that's important to do. Whether we do it with ultrasound, maybe that's a useful technique for us. But there's the practical technique as well. How easy is it to draw a blood sample from our patient? If we close the cephalic vein off at the elbow and it fills up quickly, like we do for all our spays, that's a normovolemic patient. The patient who we're struggling to get a blood sample from, where the jugulars don't distend, We can't see a saphenous vein. We can't see a cephalic vein in spite of occluding them. Those patients are most probably hypovolemic. We know that central venous pressure, certainly in terms of fluid loading and volume, is most probably a waste of time. But we can see response. That patient who has a central venous pressure that's sitting at 12 millimeters of mercury or even higher than that doesn't need fluids. Potentially those can be harmful at that stage. That may be our patient in heart failure, for example. But if it's normal, or it's low normal, or roundabout normal, it's not as useful to us. Yes, in humans they've used left atrial pressure. It also has problems as well as pulmonary capillary wedge pressures. They're not perfect. If we have a look here where modern fluid management's going in the acute setting, they're looking at cardiac output, and that's not freely available to all of us. Yes, we could use an ultrasound probe for it. They're using LITCO, lithium dilution, and PICO, looking at cardiac output. And what do? Well, they give a bolus of fluid and see, does your cardiac output go up? If it goes up, we've got a great and a positive response. That's brilliant. If it doesn't, then they think about positive inotropes. And I think we need to think about those drugs more. And I think in the future, more and more research is going to come out about using noradrenaline, vasopressors, and inotropes in managing fluid and fluid volumes. So I hope I've given you something tonight to think about fluids. Maybe I haven't given you an answer that said, oh, you need to give 30 mils per kilogram. Well, the current guidelines in the Surviving Sepsis campaign recommend giving 20 mils per kilogram of a crystalloid first up and assessing the response to it. Give it, see what the responses are, and then decide whether you're going and where you're going. If your patients are anemic, then you certainly do need to give blood. Don't forget about giving fresh frozen plasma. It's an important thing for us to use as well. And to use combination of fluids is very, very important. So if anybody has any questions at the moment, please feel free to ask. You can type them in, I think, down in the bottom corner, and we'll go through if there's any questions.
That's great, Kenneth. That was splendid. Really, really good. Now, I had a little bit of a question to start with while people are having a think. You talked a lot about, and I might have, I don't think I quite caught it. Tell me a little bit about the difference between a maintenance and a resuscitation fluid. What are the main characteristics?
Okay, with a resuscitation fluid essentially in composition is very, very similar to what our plasma would be in an electrolyte fashion. So it's usually high in sodium, low in potassium, and has an osmolarity which is very similar to plasma, so somewhere in the region of 280, 300 milliosmoles. And what it means is a resuscitation fluid we can take as a bolus and push it into our bloodstream extremely fast with fairly minimal consequences in terms of cardiovascular function and so on. A maintenance fluid is low in sodium, high in potassium. It usually has glucose and so on in it as well, some form of nutritional source, and its osmolarity is very high. So as a fluid, you can't push it in as a push bolus because you risk then the potential, for example, for hyperkalemia and a massive raise in osmolarity. What it's designed to do is to then meet your daily requirements of electrolyte. And so the two fluids play an important role.
So if you're pushing a lot of maintenance fluid in very quickly, you're much more likely to get edema and stuff like that.
Yes. And the other risk with maintenance fluids, if it extravasates out of your vein, it can cause tissue necrosis depending on the fluid that is there and depending on what its osmolarity is and its other constituents.
Certainly in the UK, a lot of our fluid is kind of obviously packaged up for us. Presumably you have the same sort of situation in South Africa where a company probably makes 6 or 7 different types of fluids that they put into bags, and then you almost get used to calling them numbers and things. And is that how you do it in South Africa, or how do the intravenous fluids get presented to you by the companies?
Yes. So what we have in South Africa if I can put it to you that way, of the resuscitation types of fluids, generally we have three. We have normal saline, which is 0.9% sodium chloride. We have Ringer's lactate is the most common. There is Ringer's acetate if you wanted to get hold of it. But essentially what they've done then is to balance part of the pH, they use lactate or acetate. And then we usually have a solution which we call Balsol, but instead of using lactate or acetate, they use bicarbonate to balance it. That is
Hartmann's, I think, is the Ringer's lactate, isn't it? Do you ever call that Hartmann's solution?
Yes, Ringer's lactate and Hartmann's solution are very, very similar in composition. They're subtly different in calcium and a few other minor things, but essentially they're very much, in principle, exactly the same solution. And then we usually have what we call maintenance or sustenance. They usually contain glucose, either 2.5% or 5% glucose in combined, usually with what equates, depending on the solution, but 1 to 2 vials of potassium chloride would have been added to it. So if we'd taken Ringer's and added 2 vials, we would get to it. What maintenance fluids help us avoid to some extent is the hyponatremia from a lot of resuscitation fluids that you get. Yeah. And clinically, certainly what I have available to me, I always keep 0.9% saline. It's useful for example, hyponatremic dogs when they present, or hyperkalemic dogs where you want to avoid potassium in those patients. And then I do use both Ringer's and Balsol. I always keep 5% dextrose water. And the reason that I keep it is, one, I can add potassium, for example, to it. I can give a totally sodium-free fluid from it. And there are patients where you're required to do that. And then I use a maintenance solution. So I think currently we've got Maintenance. I always keep one maintenance solution. And then we have colloids available at the moment because of the withdrawal of the hydroxyethyl starches. We're using gelatin-based ones, but they're becoming available again, the hydroxyethyl starches, and I'll most probably switch back to those. And then we have both blood, fat cells, and plasma. And that's essentially what sits in my armamentarium.
We have gelafusin is one of the common ones we would use in the UK, which I think is obviously more gelatin-based.
Yes, that's right. Gelafusin, it's available here in South Africa as well. It's a gelatin-based colloid. Yeah.
Yeah. That's great. I'm looking for questions, and I think you've... Oh, no, here we are. We've got one. That's great. Derek is saying, we have Hartmann's 5% dextrose saline and a mixture of 55 dextrose with saline. How would you classify these? So Derek is coming in from Kenya.
Okay.
So Hartmann's is obviously, you would say, a resuscitation fluid, wouldn't you?
Yes, Hartmann's is a resuscitation fluid. Then they had a 5%
dextrose. That's a maintenance.
Yes, it's a maintenance solution, but usually it has no other electrolytes in it. Yes. So it's useful for treating hyponatremia, for example. We would use a solution like that to give free water. Yeah. And usually if I use it, because of the glucose, especially if the patient's not eating very well, I always add potassium to it because of the risk of hypokalemia, because the glucose will drive more potassium intracellularly. So it always makes sense to do it. And then usually
to add some potassium to that.
Yes, I usually do, because you get a hypokalemia if you give too much glucose, and that you drive it. But if patients, by the way, are eating and they're eating a diet and you're giving the fluids, for example, dextrose water is a nice fluid if the patients are eating and you just want to encourage diuresis because it gives free fluid and their kidneys are working quite well. Once the glucose is removed, you're left with water, and then, of course, it encourages urine flow if the kidneys are working quite normally. So it can be useful for that. And the other one, the 50% glucose, normally we used it to treat hypoglycemic patients. So we
55
would give them
dextrose with saline.
Yes, I think it's it's usually a 50% dextrose. They can add saline, but usually that's what we would use it to
for diabetes.
Is that solution?
Yeah. With diabetics, in the early stages, we quite commonly would just give, we'd ask clients to have glucose syrup or glucose powder in their house, and just give that orally, and often that's enough to kind of bring them around if you catch them early enough, isn't it?
Yes, that's right. You can also use the 50% glucose if they don't want to mix up the powder. They can also just put it, for example, in very small puppies, I very often just use the 50% glucose, put it underneath their tongues, or if they're suckling to some extent, you can get them to drink it. So, yeah, it's any source oral glucose. As they always tell diabetics, carry a can of Coke with you. You get a hypoglycemic thing, open up your Coke, it's high in sugar, it'll correct your hypoglycemic. And if the oral route is working, and it's working well, it makes sense to use it.
Yes, as you said in the lecture. And then Derek is saying saline as well, which
saline is a resuscitation fluid.
Resuscitation.
Yes, saline would be a resuscitation fluid, and it's the traditional resuscitation fluid that comes back for years and years, and it's used in a lot of studies, and it's been shown to be very effective when it's been used. The problem that they're identifying these days is the issue about too much chloride. And just because it's sodium chloride, they've just shown that if you push your chloride levels up too high, it does become potentially nephrotoxic and leads to mortalities.
As you showed with that very nice graph as well.
Yes. So that would be the problem.
It's certainly it's a lecture that I would like to go over again because those charts were excellent. But I'm only a simple dermatologist, Kenneth. It takes time for it to sink in.
It's just to get people to think more than anything else. And yes, I'm openly to admit I've become very clueless at times. What do I do?
No, not at all. Not at all. I'm very impressed. I mean, I think it's very, very interesting because, of course, and you know, I know I was listening to one of the surgeons who went over to Syria, and he was saying they'd learnt so much now at how they deal with, you know, people, obviously soldiers who've gone to Afghanistan, just how they now treat those people compared with, you know, 20 years, 40 years, obviously, you know, the beginning of the First and Second World War. You know, just pumping fluids in isn't really the answer, is it?
No, it's pumping fluids is not the answer. There's quite a few studies which I think will be published in the next couple of months that are coming out of the conflict, dealing with fluid resuscitation and looking at their blood use. And that's going to be very, very fascinating to see.
Yeah, yeah. No, it's been really good and you know, really thought-provoking. There is so much stuff out there, and it's great that we've got somebody like you who can kind of plough their way through the literature and then you know, distill it for us. So I've really enjoyed the talk and appreciated it, and I know the people who we've had on have enjoyed it too. So we must get you back for another session on that, I think, as well, because it's a big topic, isn't it, intravenous fluids?
Yes, it's a massive topic. I mean, I just gave you a glimpse of some of the studies that I've went through, and I threw a whole lot out when I constructed this talk because it would have just taken me too long. But there's actually a tremendous amount of information that's out there.
And obviously, you know, noticing obviously quite late with you now. It's we're still 7 o'clock, but you're 2 hours ahead, so you're just after 9. And of course, we've got a couple of the vets from Kenya on. It's 10 o'clock there, so I suppose it's time for Ovaltine, isn't it? And get into bed. So I will let you go again, Kenneth. Appreciate the talk. It's been absolutely excellent, and hopefully get you on another one sometime soon for the British vets as well.
Yes, no, it's more than a pleasure. It's always great to do these things. And thanks very much for asking me. It's been an absolute pleasure.
Yeah, great. Thanks again, Kenneth. Thanks everyone for listening.